speaker, Dr. Roger Stark. I've had the pleasure of working with him the last couple of years on the Health Advisory Board of the Washington Policy Center. Dr. Stark brings 30 years of real-world clinical experience as a heart surgeon. Indeed, he started the open heart department, the healthcare department, the surgery department at the Overlake Hospital, served both on the foundation and also the governing board. And then I kid with him, after he retired in 2001, he's probably busier now, really working as an analyst. Indeed, he's written a book on healthcare reform. I think it's available. It's an excellent book. So Roger has a blend of real-world experience plus the insight of a policy analyst. So it's a great pleasure. Up next, Dr. Stark.
Well, thanks very much, Scott. Everything that I'm going to talk about this morning is in the policy brief that's in your packet on health savings accounts. Everything except the stuff that's not in there, and I'll let you know when I come to the stuff that's not in there. And what it is sort of the hot off the press numbers. But I think we could all agree, we may debate a little bit, what is the problem with healthcare, but I think we could all agree, left, right, conservative, liberal, I think we could all agree, the cost is one of the major problems we have with healthcare. 17% of our gross domestic product, over $2.1 trillion last year in this country alone. I think the thing we have to ask ourselves, though, is why are those costs so high? And healthcare is an economic model. And the reason that those costs are so high is because someone else is paying for our healthcare. 87% of our healthcare is being paid for by the employer, by state government, or by federal government. In other words, demand far outstrips the supply of healthcare. So, if we say, and we can agree that the problem with healthcare in this country is cost, and that cost is the barrier to more people having healthcare, having health insurance, then we have to ask ourselves, is there a means to hold down costs and insure more individuals without rationing healthcare? And the answer to that is yes. And the means, or that model, is the health savings account. It's the best way to increase the number of insured in this country, and it's the best way to give patients more control over their healthcare dollars and their healthcare decisions. Now, what I want to do in the time remaining this morning is go over a couple of points. First of all, just briefly the background of health savings accounts, how they originated, some of the fundamentals. Most of you understand HSAs, but we'll go over just a few of the fundamental points. When HSAs first came out, and even today, there are a few objections, 3 or 4 significant objections. And what I want to do is discuss those and then go over what is the reality. We're going to go over the current data, and that's when I'll wake you back up because that's not in the policy brief, so take your pens out at that point in time. And then we'll go over what the Washington Policy Center recommends as far as HSAs are concerned. The concept of HSAs have been around for a number of years, and they were put into law in 1996 with our favorite, the HIPAA law, the Health Insurance Portability and Accountability Act in 1996. HSAs were a provision that were stuck in there. Actually, at that point, they weren't called HSAs, they were called medical savings accounts. And there were some differences between MSAs and HSAs, but that was the first time that the concept had been put into law. That was a trial experiment. 750,000 enrollees were allowed. In 1997, a year later, Congress passed the Balanced Budget Act, and that opened Medicare to these medical savings accounts. Now, we don't hear anything about MSAs. They never really took off. They were not very popular. Insurance companies didn't pick up on them. They were not heavily marketed. And because of the federal cap on enrollees, they really didn't become popular at all. Then, one of our other favorites, Medicare Part D, which was signed into law in December of 2003, that increased the size of Medicare, probably the greatest single-step increase in the size of Medicare since 1965. Again, tucked in that huge bill, tucked way down there, was a small provision allowing for health savings accounts. So we can argue if Medicare Part D is good or bad, but tucked in that bill was what we know as health savings accounts today. And they started in January of 2004. So now, January 2004 to today, we have 5 years worth of experience. Well, just real briefly, how do HSAs work? Well, they work like an individual retirement account for medical expenses. Money accrues in an HSA in an interest tax-free environment. Funds from the HSA must be used for medical purposes. They need to be accompanied by what I'm going to call a high deductible health care plan. I know that got a little flack this morning in the first panel or the second panel, but let's call it a high deductible plan. We all know what that is. They're portable. They can be taken from state to state, from job to job. The money needs to be spent for medical purposes. If it's not spent for medical purposes, there's a 10% tax that's placed on it. And the contributions to HSAs are indexed to inflation. So in 2009, an individual contribution is maximized out at $3,000, and for a family, it's almost double that, $5,950. Okay, so much for the fundamentals. Those are all the policy briefs, and like I say, most of you folks are aware of what an HSA is anyway. Now, how about the objections? What were the objections, and what are the ongoing objections to HSAs? Well, first of all, the concern was an HSA would skim off the healthiest and the wealthiest and the youngest patients. These are the individuals that would purchase HSAs. And then problem number 2, or objection number 2, is a distinct corollary, and that is that the older, sicker patients would be left in traditional insurance plans, and the cost of those traditional insurance plans would skyrocket. The third objection was HSA enrollees will hoard their money. They will sequester their money and they will not use it, and specifically they will not seek preventive care. And then objection number 4, from a political standpoint, it's felt that HSAs would somehow decrease the momentum, would decrease the march towards universal single-payer health care coverage. So those are the objections. Now, what's the reality? Well, first of all, HSAs, 5 years experience we have with them now, they are not just for the healthy, the wealthy, and the young. Over 50% of the enrollees in HSAs are over the age of 48. And one national insurance carrier reports that 70% of their HSA enrollees are over the age of 40. Almost 50% of the purchasers of HSAs today have incomes of less than $50,000 per year. And 40% of purchasers of HSA have a home that's valued at less than $125,000 a year. So we are not talking about the ultra-rich. We may be talking about middle class, lower middle class, but clearly the less advantaged socioeconomically are also taking advantage of HSAs. Other interesting statistics, 80% of people who purchase HSAs report that they are more aware of healthcare issues and healthcare costs than they were when they were enrolled in traditional plans. And 40% of people feel that they're becoming savvy internet users to seek alternative treatment, pricing, costs, and things of that nature. So clearly, HSAs are not just for the wealthy. Now, what about rising costs of healthcare? Are HSAs causing healthcare costs to rise? And the answer there is a resounding no. Employers who report that over 50% of their employees have HSAs last year reported a 3.6% increase in healthcare spending. Employers who have no employees enrolled in HSAs reported a 7% increase in healthcare spending last year. And that's just about the national average for healthcare spending, for healthcare inflation in this country. It's about 7 or 8%. So 3.6 versus 7. So employers who are using HSAs, greater than 50% of their employees are enrolled, are saving about 50% on their healthcare costs. So clearly, HSAs are not driving up costs of healthcare.